Hello, everyone. Again, my name is Gwen Driscoll. I am the Director of Communications here at the UCLA Center for Health Policy Research, and it is my pleasure to once again welcome you to our 2015 Health Policy Seminar Series. Now, let me remember to move the slides this time. Okay, before we get started, I just want to let everyone know about our exciting next seminar, which is going to be on June 17th. It features Gary Gates, who is the Blanchard Cooper Distinguished Scholar and Research Director at the UCLA Williams Institute. Gary is a nationally recognized expert on the health of sexual minorities, and he will be talking about the essential role that the California Health Interview Survey, which we conduct here at the center, that survey plays as one of the few comprehensive sources of data on the health of lesbian, gay, bisexual, and soon transgendered Americans. If you are interested in how this rich data source can help you explore this very understudied group, please join us. Again, that's on June 17th, same time, noon to 1. Okay. One other note, we will be recording this video today, so if you miss it or had to duck out, you can see it again. We'll have it up in approximately 1 week, and you can find it in our newsroom under Center Videos. You can also learn about all our upcoming exciting seminars, events, and publications and data releases by joining our e-newsletter, our monthly newsletter, Health Policy News. And that is the sign up that you should see on the bottom URL on this slide. Okay, so without further ado, I am now very happy to introduce today's speaker, Dr. David Grant, the director of the California Health Interview Survey, and the co-author, along with Susan Holtby of the Public Health Institute, and Elaine Zahn, who was with the Public Health Institute when this study was written, but has now joined the center as a faculty associate. They are the co-authors of a new study on the 10-year trends in the health of young children in California, developed with support from First 5 California and released today and available on our website. We are, first of all, lucky to have a data source like this in which you can look at 10 years of comprehensive local level data on the health of children on a wide variety of topics. This particular study spans the years 2003 to 2012, a period in which public health efforts for children focused on childhood obesity and improved nutrition, access to low-cost and free dental services, and the expansion of children's health insurance programs. How well did California do? Here to tell us is Dr. David Grant.
Okay. Thank you, Gwen, and thank all of you for coming this afternoon. I appreciate it. In addition to thanking my co-authors, Sue Holtby and Elaine Zahn, I'd like to just acknowledge and thank the cast of folks here at the center who make these things all possible, starting with Gwen and her team, Celeste Peralta Maglin, other folks that helped this morning, Patricia Gonzalez, and of course Renee Smith. So thanks to all of you for helping to support the work that we do here at the center. So this afternoon, my presentation is organized kind of as follows. I'm going to start with a very brief framework for understanding the health of young children, more generally from a public health perspective, provide a little background on our relationship with First 5 California and the work that we've been doing together over the past decade plus. Before we go into the 10-year trends, I also want to just present a couple of figures on demographics in California and how the young child population differs from the adult population in some rather dramatic ways. Then we'll go into the data and end with some conclusions, discussions, and hopefully some questions and answers. So one thing I want to just mention right up front, I'm not an expert in the health of young children. I'm a survey researcher and a sociologist, but I do know a fair amount about population health, and it's really from this kind of population health perspective that we're looking at these trends in the health of young children. It's kind of the surveillance 10,000-foot view perspective. I'm sure there are many of you in the room and on the phone that know a lot more than I do about various aspects of some of the indicators that I'll be discussing. but hopefully this does provide some context. One thing we do have is great data, and I do have a lot of confidence in the data, and that this can tell us something about how California is doing overall. Your experience at the local level might be a bit different, but I think these data are indicative of trends we see in California. So I'm going to start with what I think is a fairly safe assumption for trying to understand some of the changes in what we see. And that assumption is that all parents want what's best for their kids. That could be the best in terms of health, education, opportunities, physical, mental growth, etc. We probably all know some exceptions to that rule, but I think it's a fairly safe starting point. And then from the social ecological model, where we see that child, and especially for children 0 to 5, they're not out there on their own. They're within the context of their families, in a neighborhood, a community, and a social and cultural environment that's going to differ for each of these kids. And then there's a whole set of external factors, policy, political environment, economic conditions, which have varied widely in California over this 10-year period, a social culture environment, and a whole host of other factors that have interplay with families, communities, neighborhoods, and have an impact on what we're ultimately measuring here using the CHIS data on things like health insurance, oral health, obesity, preschool enrollment, and school readiness. And I would suggest that as we think about understanding some of the changes we see in the data, that some of the outcomes are more susceptible, more immediately impacted by some changes than others. And we can change things like health insurance rates with policy much more quickly than we can change obesity and eating behaviors and physical activity by either legislation, social messaging, or other interventions. Okay, so trying to understand that framework, we're now going to talk a little bit about the work we've been doing with First 5 California. And First 5 California, as many of you will remember, was passed back as Proposition 10 in California in 1998. And the public persona leading the charge for the passage of Prop 10 was someone known as Meathead. Now, if you don't know who Meathead is, then it's just evidence of a real generational divide. All of us older folks in the room remember Rob Reiner as the actor in the 70s sitcom All in the Family, known affectionately by his father Archie Bunker as Meathead. And Rob Reiner, after his acting career ended, became a political social activist and a real champion for children in California, and really led the charge here to pass Prop 10. And it imposed a 50-cent per pack tax on cigarettes in California, and that funded First 5 to pursue a mission of improving the lives of young children and their families in California. And CHIS became involved with First 5 back in 2000, supporting the very first data collection cycle of the California Health Interview Survey. And CHIS is a cost-effective way for First 5 to meet some of its mandated goals on data collection, research, and evaluation of health, the social and emotional development, and school readiness of young children at both the state and county levels. We've had the advantage in CHIS of having consistent measures on a lot of young indicators of health for young children over time, which gives us the opportunity to explore and compare these changes over time. We do a couple of things specifically for First 5 in the data collection for young children. This is the most detailed method slide that I'm going to present this afternoon, but there's two things that we do. So when we interview households, we select, if there are children under the ages, or between the ages of 0 and 10, we select one child to be the target of our child interview. If there are children in the 0 to 5 age range and the 6 to 11 age range, we double the selection probabilities of selecting the younger child. And that helps us boost the sample of First 5 California's target population, the 0 to 5 age group. The second thing we do is something that we call child first interviews. And I hesitate to bring this up because it's rather complicated, but it's an important thing that we do to increase the sample of children. So when we interview a household, the first thing that we do is what we call a screener interview. And in that screener interview, we identify how many adults there are in the household. We select one adult at random to be the adult respondent. And then we find out if there are children and adolescents in the household. And if there are children and adolescents, we go and select a child and adolescent. Before 2005, when we started this, we often would leave children in households uninterviewed. We wouldn't collect any information, and that's because we had a strict protocol of first interviewing the adult, then doing the child and teen interviews. So by doing what we call child first interviews, when we do that screener interview, if some other adult is selected as the adult respondent, we ask the screener respondent, are you also the parent of that child in the household? And if they are, that parent can consent and then answer questions about that child's health. And by doing those child first interviews, we've enhanced the child sample by almost 20%. And in our most recent data collection effort, 13-14, almost 1/3 of our interviews were done using this child first method. Oops, wrong button. So I promised I'd show a little context, demographic context, before getting into the trends data that we'll look at in just a minute. And California is not only a very large state, but a very diverse state. There is no group that has a majority racially and ethnically in California. The largest group is whites at just about 44%, followed by Latinos, Asians, and African Americans. If we look at the 0 to 5 population, in contrast, it's a much different picture. And those proportions of whites and Latinos are swapped and exacerbated or enhanced, so that we do have a clear majority group in California, and that's Latinos. 54% of children 0 to 5 are Latino. A much smaller, only quarter of the state, 25%, identify as white, 6% roughly African American, and about 9% Asian. If we look at income, and this is income measured as percent of the federal poverty level, and we kind of go stair-stepping from in poverty 0 to 99%, low income 100 to 199, 200 to 299, and then 300 and above. In a lot of the analysis that you'll see, we've divided this in half, so we're looking at kind of low income populations under 200% and then upper income above. And as we see here, most adults, almost half, are in that highest income category. Picture's not quite so rosy for children. Only 1/3 of children 0 to 5 live in those upper income households, and nearly 1/3 live in the very poorest households of under the poverty line at 0 to 99. And if we combine those two lowest income, the majority, 53% of young children, live in low income households. So just in brief summary, the child population is a lot different than the adult population. The majority of 0 to 5 kids are Latino, and the majority, almost identical proportion, are low income. So now that we've identified that group and know a little bit more about them in the context of California, how are they doing in terms of their health, access to care, other issues? So to answer that question, we have taken just data from 2003 to 2012. We've limited the analysis to the population 0 to 5. We have disaggregated some of these indicators by race, ethnicity, and or income. And the indicators that we will look at include health insurance coverage, usual source of medical care, dental visits, overweight for age, positive parenting activities, and preschool attendance. I also want to mention that everything we're showing this afternoon is state level data. County level data is available through CHIS, and you can access that on the CHIS website or through the center's homepage, both through Ask CHIS. You can look at more granular data on children through Ask CHIS Neighborhood Edition down to the zip code level. We also have county level PDFs in a product called Health Profiles, and we have those for children, adults, by race, ethnic group, etc. So there's a lot more information and a lot more local information available from CHIS through some of those other tools. So the first slide we're going to look at is the uninsured rate, and this is children 0 to 5 who are uninsured at any point in time in the last 12 months, going from 2003 to 2012. And overall, that middle line in the center in green shows almost no change over time from 2003 to 2012. But we do see in that top blue line for low-income children a pretty steady downward decline from about 13% in 2003 to just under 9% in 2012. And that is a significant change over time. The gap, however, between the low-income and the upper-income kids does remain significant, although the gap has been narrowed. If we look at the type of insurance and health insurance coverage that these kids have, there's been a pretty significant and dramatic change over time, from starting with nearly 60% of kids with private coverage back in 2003, and a steady increase in the proportion of kids with public coverage. So between 2009 and 2012, we see those two indicators cross with the majority of kids. And that's not surprising when we just saw earlier that 53% of kids in California, 0 to 5, are low income. Almost in an identical proportion are covered through Medicaid or Medi-Cal and other programs, and a relatively flat and stable uninsured rate of about 4%. Again, that's point in time versus the past 12 months, which we saw earlier. And then finally, in terms of access and insurance, we look at usual source of care, and this is kids who had a public usual source of care by racial ethnic group. Overall, that black line in the middle shows very little change, and there's not a whole lot of change either among the racial and ethnic groups, but there are some really big difference between groups, and the difference between Latinos, which are pretty steadily at 40% using a public source, are different than other groups. The one other change there is that's significant is the increase among white children in a public source of care, going from about 11 to almost 14%. Yes, Nadi?
Can you define public, please?
Public sources are not private doctors' offices, so these are largely community clinics, safety net providers. So in brief summary here in terms of coverage and access, uninsured rate is pretty low and flat over time, about 7.5% for any time in the past year, about 4% at any given point in time. And significantly, the income gap has been reduced, with more poor children with coverage in 2012 than we saw a decade earlier. Public coverage has replaced private coverage as the most common type among young children, and almost all kids had a usual source of care, and that changed little over time. Okay, we're going to kind of leave the access and insurance world and look at some other indicators. And of any charts that I could show today, this is the best, most positive chart I have. So enjoy it. This is dental visits over time. This is a proportion of kids 0 to 5 reporting a dental visit in the past year. We had big income gaps and low rates back in 2003, and that gap has narrowed so the income gap is non-existent by 2012, and it has increased rather dramatically for all groups. Unmitigated positive results here. I guess the one thing we could hope is that this will continue to increase, that trend upward. We'll have some data from 2013, 2014 very soon to tell us that, but this is really significant progress over the past decade.
Is that due to a policy change, or is that due to kids getting more mature, or both?
Could be some of both, but we'll
Can you repeat the question?
Sure. So what's the cause of this? Is this more kids getting access to coverage? Is it policy change? Both? And we'll talk about some of this a little bit later. One thing I will mention is First Five California and a number of other organizations have really made a big effort to support oral health in California. First Five invested over $7 million, largely through working with WIC in a partnership to expand awareness and help parents become more aware of the importance and expand usage of dental care for those young kids. As, you know, a lot of times parents don't think kids really need dental care. They're going to get another set of teeth. They may not have teeth, or they may only have a few teeth. Yet, you know, oral health is a really big problem for kids in school readiness, and one of the leading reasons that kids miss school. So oral health is a big deal, and this is a really positive development for California. Overweight by income. Now, we don't talk about obesity for young children 0 to 5 because these are parents telling us about their kids' height and weight, and it's not great data. Parents are often guessing. We know that they guess more on height than weight. We take these with a little bit of a grain of salt, but I think what's important to keep in mind is that we've measured this the same way for the past 10 years. So the changes, while the results may not be perfectly accurate, the way we've been measuring this is consistent, and I think the trends that we see have some relationship to reality. That green bar on here shows overall no change in overweight by age in California as a whole, yet we do see some significant differences by income. Low-income kids have stayed relatively flat, increasing slightly, but upper-income kids, the overweight for age level has been cut dramatically from about 12% in 2003 to under 8% in 2011-2012. So here we see a growing income divide in terms of overweight among young children over time. Some of you may remember in the great green room there was a telephone and a red balloon and a picture of the cow jumping over the moon. Reading to kids is an important thing, and I'm not sure I knew it was important to read Goodnight Moon to my kids when they were young, but it seemed like a good thing to do, and it always seemed to help with the routine of getting them from up and running around to getting into bed and staying in bed. There's been a lot of research in young children's brain development over the past 2 decades, and it is an important and critical time for brain development, and something that you can't get back. You can't read to your kid later to make up for the development of all that dense synaptic neural network when they're in those young years. Reading with kids every day, singing, dancing, playing with them, getting them out, stimulating them with something besides a television or an Apple iPad is an important thing to do. And First Five California has a relatively new campaign called Read, Sing, Play, which is encouraging parents to engage in these activities with their children every day. The Clinton Foundation has a similar campaign nationally to encourage these kinds of activities. Before these things took place, First Five California said, we want to measure some of these activities about what parents are doing. So a decade before they initiated their campaign, we've had these same indicators in the CHIS questionnaire, which has been great because we've been able to follow and track these things. A lot of times people say, oh, the only measures in CHIS on kids are bad things, secondhand smoke exposure, obesity. Here's something really positive, and people really like to look at these indicators. And again, these are available not only at the state level, but for counties as well. And we've seen improvement, and it's been statistically significant improvement in each one of these activities over time. So that is another really good story. The not so good story, and we don't present this data, is there are some rather significant differences in these activities by income, with lower income children much less likely to be read to every day, sing, play, dance, or taken out on a daily basis. But overall, we're seeing some progress. And then if dental care was the highlight, preschool enrollment is the low light. As hard as it is to believe, with all the research over the past couple of decades about the importance of young children's brain development and the importance of high quality preschool for kids, from things like the Absidarian Project on, investing in high quality preschool is a really good investment. Kids that go to high quality preschool are less likely to end up in jail. They're more likely to graduate from high school and college. They're more likely to have better health and a whole host of other positive outcomes. Yet, we've seen a decline in preschool enrollment around 3 and 4-year-olds from about 37% in 2003 to 30% in 2012. And there's again a real significant division in preschool enrollment by income, so that upper income kids are more than twice as likely to be in preschool as 3 and 4-year-olds as lower income kids. Now, there's been a lot going on in preschool lately. President Obama introduced the concept of universal preschool in his State of the Union address in 2014. First Five California has invested heavily in preschool since the very beginning. And I'm not showing trends here. We've measured this in a consistent way over time. There are other sources of preschool enrollment data that will present different numbers because it's measured differently. But we do see this decline. The National Institute of Early Education Research at Rutgers University just published a report last week on preschool enrollment and talks a lot about universal preschool. It rates states. California was right in the middle of the pack in terms of access to preschool for 3 and 4-year-olds. I think we were ranked 26th. We hit only 4 of 10 quality indicators. I think there's a long way to go in California to improve preschool enrollment for young children. So, in summary on these other indicators, overall a big thumbs up and super progress on dental care and visits and the elimination of income disparities. At the same time, we've had essentially no change in the weight of overweight by age kids, and that's also been a high media, Michelle Obama First Lady, just everywhere campaign, yet significant differences and widening income disparities in overweight by age for kids. I've got kind of the thumbs up, thumbs down on the read, sing, play activities. We do definitely have gains over the decade, and those gains are significant, but the income disparities remain wide and are persistent. And then a thumbs down on the decline in preschool enrollment and evidence of a large disparity by income in kids enrollment, 3 and 4-year-old enrollment. So in conclusion here, just in terms of the trends that we've seen, I think it's a real mixed bag of progress, stability, and some worsening. Unmitigated gains in dental, progress in talk, read, sing, little change in health insurance, usual source of care, and overweight, and declines in preschool enrollment. When Sue, Elaine, and I were going through this, we discussed, are we really seeing a polarization by income of kids in California? And I think there definitely is some evidence of that, depending on some of the indicators. We've seen declines in polarization by income in health insurance and dental visits, yet increasing income gaps for overweight for age, talk, read, sing, and preschool enrollment. And that takes me back a little bit to my opening framework of how kids are doing and how can we kind of understand some of these changes that we see in the data. California, I think, deserves some credit here. The state has been relatively consistent and effective in promoting policies to expand health insurance coverage and improve access to care and dental care for children. That's through programs, as I mentioned earlier, like First Five, partnering with programs like WIC, aggressively going after federal dollars and matching dollars to improve access to care through the S-CHIP program. We've seen a decade in California of rather extreme economic variability, yet the state has stepped up to the table when private insurance went down, public insurance really saved the day in California. And I think in other states with other leadership, that would not have happened. So I think those are some really positive outcomes that we've seen over time. We have some positive change in other areas, but I think things like overweight by age, preschool enrollment, may be more challenging. We know that we've all known for the past couple decades that the United States has an obesity problem, yet it continues among adults to get worse. People know that eating a healthier, fresher fruit, vegetable diet is good for them, more exercise is good for them. It's really hard to change some of those behaviors. It's hard to legislate change. And I think the behaviors and outcomes that we see in kids that are dependent on those behavioral changes are more difficult to make and may mediate through a whole series of other factors where it may be easier to have those changes in upper middle income households and environments than in poor neighborhoods and communities. And that leads me to kind of think about how do we prioritize in what we do as a state moving forward. And I think we need to make sure we can identify those kinds of issues where the state and policy can have an impact. And I'd say one of those that is ripe for change is preschool enrollment, where the state can take a much more active role in helping enroll kids through what has been a really fragmented, privatized system of preschool and moving that into a more integrated network with links to things that we've seen work really well for health insurance programs like no wrong door eligibility, fast lane insurance where kids are getting enrolled in CalFresh and moving right into Medi-Cal and other kinds of coverage. Those kind of policies I think can really help us make sure that kids moving forward will have greater opportunity and greater health in California. So thank you very much, and I look forward to any questions. Yes.
I'm going to moderate questions between people in person and the people online. We have a question from someone online about the landscape since this study was done regarding dental benefits, and specifically some of the controversy over Denti-Cal, organizations like Western Dental saying they will not accept new Denti-Cal patients. How might that affect these statistics? And can you repeat the question?
Sure. So admittedly, these data are a bit dated. These are all pre-ACA data. The most recent year is 2012. And so how have changes in the Denti-Cal program and, for example, Western Dental saying they're not going to expand coverage for dental benefits for young children, how may that affect the trends? I think it's of concern. Some of the things that we've seen also is, even though we saw health insurance, an overall decline in access for poorer kids, there was actually a bit of an uptick among the upper income kids. And it may be that some of the working poor families are going to get left out. And most of the ACA is really expanding coverage for adults, not children. Children coverage has really been maxed out through what had been the SCHIP program and then changes in instituting those changes in the ACA. And you know, what's going to happen in dental care? I think there's been a lot of variability in dental care over the years, and the Denti-Cal program has kind of come and gone over economic recessions in California, yet we've seen that increasing uptick. So I think, you know, I don't know the answer to the question. I think we'll have some data soon, in just a couple months, that will help us answer these questions. And the reason I say that is because the CHIS 2013-2014 data will become publicly available in early August, and we'll have another data point out there to see whether that trend continues or has come to an end and starts to tick down. But I think a lot of this is in flux, and a lot of this is in change. I think the positive thing is that we've seen a lot of momentum, and there's a lot of growing awareness about the importance of oral health for young children. Yes.
So just a follow-up to that, is the way the question is written, does it distinguish between dental visits at a dental office versus a mobile clinic versus a school clinic, or some of those are variable and might change over time?
Great question. So the question was, in CHIS, do we differentiate the kind of facility where a child is getting dental care? Is it in a dentist's office? Is it a mobile clinic, at a school-based clinic, etc.? No, we don't know the environment in which those kids are receiving health care or oral health care. We know a little bit more about their medical care and where they receive their medical care, but not their dental care. There may be some other data sources. Nadi Parat, who was in here just a moment ago, has stepped out. Nadi does a lot of research on oral health and is a great source of information, so I was hoping to turn it over to Nadi. But
David, we have an online question. Is there similar data about a growth in utilization of vision care by Medi-Cal eligible kids?
Great question. So the question is, do we have similar data about growth in use of vision care by Medi-Cal eligible kids? We do not. CHIS includes a lot of information. Our questionnaires are always too long. I thank anyone who has ever completed a CHIS interview. But that we don't have information about children and vision use of vision benefits. We have had some questions for adults over the years about whether they have vision coverage, but not among young children. Yes, Sue Babby.
Very nice talk, Dave.
Thank you.
I was curious about your findings of declines in preschool enrollment, as well as the disparity by income, and whether you were able to look at the trends over time broken out by income groups.
It's a bit of a challenge. Oh, so let me repeat the question. So the question was some curiosity over the trends in preschool enrollment and the decline, and whether we're able to trend that over time and trend it over time by income groups. The sample size is a bit small on that one. It's 3 and 4 year olds only. So when we start to separate the 3 and 4 year olds by income, the data gets a little bit thin. And I didn't show the full trend there, but there was some growth actually from 2003 to 2005, and then it flattens off, and then it declines after 2007. And I think a lot of what we're seeing there is economic recession and kids and parents not able to afford preschool in the 2009 recession onward. And you know, we've had somewhat of a recovery. There has been growing awareness and interest in preschool. There's federal support, and there's all this kind of seeming momentum in increasing preschool enrollment. So so the quick answer is no, we didn't look at the longer trend by income. And the second piece is I hope that what we've seen is a bit of a temporary decline, and that it's really recession related, and that we're going to see a return to an increase in rates for preschool enrollment. I think, though, that as we saw with health insurance coverage, it may require some more support through policy and resources to not only get more kids in preschool, but also to make sure that we have enough preschool teachers and trained teachers to support those kids and preschools. Yes.
I'm a rental property owner in South Los Angeles, and I know that as a rental owner, I have a whole group of rental owners in South LA that we work collectively together to make sure our tenants know where there's resources, they have better quality of life, which also means they can pay the rent back. In your study, because we're a great opportunity for that continuity of resources, did you study, and I can guess on the answer, but did you study actually how many were in rental properties? To use that as a resource to solve the problem?
That's a great question. So the question was, did we look at kids and their health and differences of kids who are renters versus kids that live in family-owned occupied housing? Is that reasonable? So no, we didn't, but we have those data in CHIS. We could certainly do that, and I think the other comment preceding this was that kids with better access to health care are families that are better renters, and we could look at that. We have that information, and it might be an interesting thing to explore, and maybe we should talk later and see if we can do some work together.
I'm a volunteer director of the Apartment Association of Greater Los Angeles, so we will give you that access if you'd like to create that continuity.
That's fantastic. Thank you very much. Other questions? Yeah.
Is there any data in the survey on like kids with special needs or any autism spectrum, anything like that?
We do. So the question was, is there any information in CHIS on kids with special needs, autism, spectrum disorder, etc.? And yes, we do have information on kids, and I think we've been collecting that since at least 2005, 2003, including some questions, and some of the questions have changed a bit over time. We do have a fact sheet that we put out, I think, in 2007 on kids with autism spectrum disorder. We soft launched that because we were really nervous. We saw this tremendous jump in the number of kids diagnosed, and after we released that a couple months later, the CDC put out something that mirrored our trends, and it's kind of alarming to see those trends in the diagnoses of kids with some form of a spectrum disorder. We do have that, and First Five is also supporting questions on doctors screening kids. So asking parents of young children, was your child screened for a developmental delay? Did the doctor, and we go through kind of a checklist of things that doctors should do with young patients to explore their development. And then not only was the child screened, but then was the child referred for further screening. So we do have some of that information. And I would also encourage people on the center's website. We have a great publications archive and search tool, and there may be, there's 250 plus peer-reviewed journal articles with CHIS data and counting, and there may be something in there that looks more specifically at that's been published. So. Great. Any other questions? Well, thank you very much. Appreciate it.